Meralgia Paraesthetica is a condition characterized by tingling, numbness, and burning pain in the outer thigh. It is caused by the compression or irritation of the lateral femoral cutaneous nerve, LFCN, which supplies sensation to the skin surface of the thigh. Key features: symptoms: tingling, burning, numbness, or stabbing pain in the outer part of the thigh. Cause: compression of the LFCN, often due to tight clothing, obesity, pregnancy, prolonged standing, or trauma. Diagnosis: based on clinical history, physical examination, and sometimes nerve conduction studies or imaging to rule out other causes. Management: conservative measures like weight loss, avoiding tight clothing, and local corticosteroid injections can help. In resistant cases, nerve release surgery may be considered. It's a condition that is mostly benign, but can cause significant discomfort. Meralgia Paraesthetica, a detailed overview. Epidemiology, prevalence. The exact prevalence is not well established, but is considered a relatively rare condition. It is thought to occur in about 4.3 out of 10,000 people annually. Risk factors. It is more commonly associated with obesity, pregnancy, diabetes, trauma to the hip or pelvis, and wearing tight belts or clothing. Age and sex distribution. Age. Most cases occur in adults between 30 to 60 years of age, with a peak incidence in the 40s. Sex. It has a slight male predominance, although pregnancy makes women more vulnerable during certain life stages. Diagnosis. 1. History and clinical presentation. Patients typically present with numbness, tingling, burning, or pain localized to the anterolateral thigh. Symptoms worsen with prolonged standing, walking, or wearing tight clothing. No muscle weakness or reflex abnormalities are seen, as the lateral femoral cutaneous nerve is purely sensory. 2. Physical examination. Reproduction of symptoms with palpation of the area over the inguinal ligament. Tinel's sign, tapping over the nerve's course, near the anterior superior iliac spine, may provoke the symptoms. 3. Confirmatory tests. Electromyography, EMG, and nerve conduction studies may help rule out other causes of neuropathy, but are often normal in MP, as it is a sensory nerve. Imaging, MRI, or ultrasound may be used to rule out other causes like herniated discs, pelvic masses, or trauma, especially in unclear cases. Diphyragnos. 1. Lumbar radiculopathy, L2, L3. Similar sensory symptoms may arise from nerve root compression in the lumbar spine, but radiculopathy often presents with low back pain and may involve motor symptoms. 2. Hip joint pathology. Osteoarthritis or bursitis of the hip may cause referred pain to the thigh, but typically involves joint pain and limitation in range of motion, which are absent in MP. 3. Femoral neuropathy. Involvement of the femoral nerve leads to motor deficits, weakness of the quadriceps, in addition to sensory disturbances, distinguishing it from MP. 4. Diabetic neuropathy. More generalized neuropathy with involvement of multiple nerves, and the pattern is more diffuse and symmetric, affecting both legs. 5. Vascular disorders, e.g. deep vein thrombosis. Vascular issues would typically present with swelling, redness, and pain, and can be ruled out with Doppler ultrasound if suspected. Management. 1. Conservative measures, lifestyle modifications, weight loss, avoiding tight clothing, belts, or prolonged standing. Physical therapy, stretching exercises to relieve tension in the affected area. Medications, NSAIDs, for symptomatic relief of pain and inflammation. Anticonvulsants, e.g. gabapentin, pregabalin, to manage neuropathic pain. Tricyclic antidepressants, e.g. amitriptyline, for chronic pain management. 2. Injections. Local corticosteroid injections can provide temporary relief by reducing inflammation around the nerve. Nerve block. An anesthetic injection may help in diagnostic confirmation and offer relief. 3. Surgical intervention. Nerve decompression or neurolysis may be considered in patients with persistent or debilitating symptoms who do not respond to conservative treatments. Neurectomy, as a last resort, involves cutting the affected nerve, which leads to permanent numbness in the thigh, but may relieve chronic pain. Prognosis. The prognosis for MP is generally good, with most patients responding well to conservative measures. Surgery is rarely needed, but in cases where it is performed, patients usually experience significant relief.